you learn how to get curious about what's going on in your body, because an emotion, including anxiety, there's an anatomy, right? It's a thought. That's what it is. It's a cluster of thoughts. It's a cluster of internal sensations and urges to get rid of it or to get more of it if it's a pleasurable emotion. That's the anatomy of an emotion. And we try not to have those physical sensations. That's just like a normal thing if it's uncomfortable. And for whatever reason, my anxiety shows up in my stomach.
Welcome to the Mind Meets Medicine podcast, where we believe the future of healthcare is mind meeting medicine. Hi, I'm Kaila, a licensed therapist and founder of a mental health care clinic.
And I'm Dr. Sir, a board-certified psychiatrist.
Together, we will join the fields of medicine and psychology to provide education, elevate guest perspectives, and foster curious, informed conversations.
The contents of this show are for informational and educational purposes only, and are not intended to replace professional, medical, or clinical advice. This content does not establish a patient-provider relationship. Always seek the guidance of a qualified healthcare provider for any questions you may have regarding your health or treatment. If you are experiencing a psychiatric emergency, please call emergency services or go to your nearest hospital immediately.
Welcome back to Mind Meets Medicine. I'm Kaila.
I'm Dr. Sir, and we're super excited to have a guest here today. A very special OCD and anxiety expert is the founder of Choice Point Counseling in Menlo Park and is a board-certified clinical psychologist. Welcome, Dr. Lorraine.
Thank you.
You're welcome.
Thank you. This is very intimidating. Looking at these two beautiful people across from me, so professional. Thank you. I'm really excited to be here.
Yes. Thank you. It was hard to even get started because we're having so much fun, just like in preparation.
I just want to be your friend.
We are now. That's the thing. It's mutual. The feeling is mutual.
Well, I was thinking maybe you could just give us a sense of how you came into this work and also how you found yourself in this niche area as well.
So I'll think about where I want to start. How I came into this work. We'll start there.
That was like a hard question.
It is. And I expected it because all your other podcasts start with that question. So for me, growing up right outside of New York City, I visited a lot because I have an aunt that lives there. In any case, I grew up like in a very middle-class family right outside of New York. And we were, pretty traditional for people my age. You don't talk about your feelings. You just kind of keep your mouth quiet and you just do what you're supposed to do. That's how I was raised. And then we'd go into New York City and I would see people who were homeless or who were talking on the street. And it's so different than the sheltered environment that I grew up in. And I'd found I was always curious, who are these people in a curious way? I wanted to talk to them. I wanted to find out who they were, what happened. And I would wonder, why are they like this and why am I not? And in addition to that, I also did have panic disorder as a teenager. It was untreated. So I think the two of those things combined made me realize this is what I want to do. I want to understand people, what makes one person resilient and not have anxiety and one person very resilient and not struggle with these things, because clearly, it runs across the board, whether you're homeless or not. Whatever environment you grew up in, mental health doesn't discriminate. So I think I just was curious about that. And my mother told me, she still says that I was like the School of International Affairs, starting even in nursery school. I wasn't really drawn to people like me. Well, they spoke a different language or they looked differently than me. I just was very curious and wanted to be friends with people that weren't like me. And so I think that's still true. I just have a lot of curiosity. And I think as a therapist or a clinician, that's probably a really important skill to have. So I always knew I wanted to be a psychologist, always.
Is that where you started in your career?
No, I did not. I worked in corporate for a long time because I didn't know that I was smart enough to become a psychologist. Truth be told, my parents would not, they did not want me to go to school for psychology. And this is not their fault, by the way. They were doing the best that they could. They thought I should be an accountant. I used to be really good with numbers. That's not true anymore. But I did not, no, I was in business. So I was in marketing and sales. And I went back to school as a second career. after I had my daughter and just decided it's time. And I never looked back.
Well.
Never.
That's awesome.
Yeah. It's so funny how, like, it's not like this, like, encouraged career path to take.
I know.
And yet people get here in their second careers or their third careers and they're so happy they finally did it. So, and I hear it so often.
I know.
Yeah. A lot of attorneys.
Yes. Yeah. People, there's a lot of like, you're never going to make money or you're never, it's like, there's so many reasons to not go into psychology. Also, you know, I mean, if we're listening to our parents.
Yeah.
And it's just not encouraged. It's just not something that's like a thing that's people do. And then, you know, the classic, are you reading my mind? Or are you judging me? Are you, you know, you're just, it's all going to be my fault.
But I'm so glad that I did have the other background, because I feel like for a lot of the clients that I see that are executives and work in large corporations, I understand that part of it. And that I've had both of those. So it's been very, you know, I use what I know to help me.
Oh, being a mom, being, you know, like having another career, it informs being a therapist.
Life experience.
Yes, it's just the life. I know.
You can't learn that, you know, through a book.
I know.
So
in a classroom, it doesn't come. Yeah. So how did you start working with anxiety and OCD?
Yeah, that's a great question, because I didn't start there. Even though I did have panic disorder as a teen. I didn't start in anxiety. My initial training was in trauma. I worked at a trauma clinic. I did the trauma track through PAU, or formerly PGSP. My dissertation's in trauma. And then through that, it evolved into working with addiction. I think you mentioned you have worked with homelessness. I used to work with homeless substance dependent vets, and I loved that. And I think that's just a natural path of, you know, working with trauma. You end up doing things that come along with it at times.
Was that in New York?
No, this was here. I worked at the Palo Alto VA, HVRP, which no longer exists anymore the way it used to be. But in any case, I did that for years and I loved it. But I did want to broaden, you know, the breadth of what I did, especially as a new therapist. So I worked at a hospital and saw everything, just general adult psychiatry. And somehow that morphed into specializing in eating disorders, I think, from trauma and substance abuse, chemical dependency. I think eating disorders are in that department as well. And then I got trained in family-based therapy, which is the gold standard for treating teens with anorexia and other eating disorders. And I did that for a while. I worked in the PHP IOP, which is for people who are listening, partial hospitalization, intensive outpatient program for eating disorders. And that's how I also got into parent coaching.
Yeah.
And there's a huge overlap between eating disorders and OCD.
There sure is.
I almost think of them the same with different presentations. And obviously, medically, there are some differences. But the way the rigidity in the brain and the intrusive worries and the obsessions and the compulsions for eating disorders looks a little bit different. But there's such an overlap that I just decided when I left and went to the Feeling Good Institute, I decided I wanted to get some training in OCD because I saw it. I kept seeing it and I thought I don't have the professional training. So I did a deep dive.
Yeah.
One thing, I am a little bit of an overachiever for which most of the people are in this area. I did a deep dive to that training as well. And so definitely I consider myself an anxiety specialist and OCD specialist.
Mm-hmm. Yeah, you done what, ERP, space?
Yeah, space treatment.
I did the space.
Oh, you did? Oh, it's such a good, it's great.
Yeah, it was awesome. It takes forever to get in.
I know. Did you do
so quick?
There's a second one also that doesn't failure to launch.
Yes, the failure to launch, and then there's also RFID.
Yeah, that's that. They do that the same. So
cool.
I did space. I do ERP. I went to BTTI, which is like the being a graduate of BTTI through IOCDF is like the thing that you want to do to really learn it, because the famous people in OCD teach there. So I did that. I'm a graduate of that. But I also did I-CBT, which may be new for some of you because it's a newer treatment in the US. It's called inference-based cognitive behavioral therapy, which is a different approach with similar outcomes to ERP.
I think I only know one other person other than you that's had training.
I'm sure I know them, probably, because it's a small, but it's wonderful to have that in addition to ERP, because sometimes exposure is just too much for someone at first. So we have to get them in, give them treatment, build a relationship. And after I-CBT, I feel it's often easier to move into ERP and get more, they're able to stay in the treatment. I can't think of the word, but they don't leave, So, So
there's less attrition.
Thank you. Yeah, that's the word.
I was curious if we could talk a little bit about what OCD is and how it's different from anxiety, or how do we conceptualize and distinguish, and why is it important to make the device?
You asked the $1 million question, sir, because we do workshops on this. And what's the difference between generalized anxiety and OCD? And different people have a different...
I feel like illness anxiety also kind of gets in there. And
OCD. Yeah. So I would say they're very close cousins. And let's put illness anxiety, even though it has a separate diagnosis, the conceptualization is exactly the same. It's just the theme around illnesses. That's how I see it. Okay. So when I have clients who have generalized anxiety, sometimes I myself even get confused. Is this OCD or is this anxiety? And the truth is, it really doesn't matter, because you could treat them the same. It matters for medication, that is for sure. But OCD, the traditional definition of it, is when someone has intrusive, unwanted thoughts that seem like they come out of the blue. So let's think of this, and with generalized anxiety or anxiety in general, it seems like more day-to-day worries, more normal. I don't really like the word normal, but typical things like, are my kids okay? Am I going to make it in time? Are my finances okay? The things we worry about to live. So that's kind of those are worry thoughts, and they're annoying thoughts, but they don't always come as intrusive and nonstop. OCD, the thoughts are truly intrusive and often ego dystonic, which is, you don't want the thought. So we want the thought, I'm going to worry about my kids or money. Those are things that are going to help. Not that we want to worry, but those don't work against who we are values wise. But if an intrusive thought comes up about, I'm going to hurt someone, which, by the way, harm OCD is a very common form of OCD, and it creates so much shame, whether it's fear of self-harm or harming someone else. It's just a thought, but it's very bothersome. It doesn't feel like this person wants the thought. It's not ego syntonic. So that's how I distinguish between the two as far as what is the intrusive thought. The other part of OCD, as well as anxiety, is the compulsion. So in OCD, we do things to get rid of that worry thought, which the traditional thing, is wash your hands, or in that movie with, the movie where he walks over the cracks. I can't think of the name of the Jack Nicholson is in a movie about OCD. It's an older movie.
Oh, I'm so bad at it.
Well, yeah. Someone there's you can see the
ritualistic behavior
is what we know and can target, but there's also can be a lot of mental compulsions that we can't see. They're covert. So people might be counting in their mind or reassuring themselves. But whatever they're doing, it's to get rid of that intrusive worry. It's to reduce anxiety. That's OCD. In generalized anxiety, we often do the same thing. We worry, we ruminate. Generalized anxiety, there's just lots of worries and lots of rumination or worry that just won't quiet down. And we quell it by talking about it, by problem solving. So it's still the same function of to get rid of the anxiety. So they're close cousins. And that's what I always tell people.
Yeah.
I don't know if that answered your question.
Yeah. Yeah.
It's great.
I was wondering because when I was doing OCD training and practice in residency, there was a lot of discussion about pure O, pure obsession.
Yeah.
And like, how do you conceptualize OCD? Is it possible to have OCD if it's purely obsessional? And then there was conversation about, oh, well, it's the compulsive behaviors just aren't behaviors, they're compulsive
Think thoughts. Yeah.
And then, it's kind of like this whole
No, I remember, and we don't even call it pure O anymore because it is in pure O. When there is obsessions in your mind, we call them now mental compulsions, and they are behaviors. So the way I think about it is an intrusive worry. The obsession is like someone throws a baseball towards you. It's passive. You're not throwing the baseball. It comes towards you. When you're mentally compulsing, even though we can't see it and it's covert, you're reassuring yourself, you're seeking reassurance, you're doing something active in your mind, you're counting, you're neutralizing thought. There's a million types of mental compulsions. And as an OCD specialist, you have to get creative. And even on the Y box, which is a kind of the gold standard to figure out if someone, where they are in their OCD spectrum, it doesn't go over a long list of mental compulsions. So you have to start really getting curious like a detective when you have this intrusive worry. What's going on in your head? Because that's active. It's like you're trying to hit the baseball, right? You're not just sitting there passively and it just comes at you. You're doing something to get rid of it. So that's how I conceptualize mental compulsions. And that's greatly know that now because now a lot more people can find out, yes, you have whether we want to call it OCD or anxiety or whatever it is, there's something going on that we can work on to help you feel more at ease and not. I mean, OCD can be debilitating. It's like living in a cell in your head. It can be, or it can be very mild. I don't want to scare anyone. There's a spectrum.
Yeah. But definitely, at least the cases we see in psychiatry tend to be, especially impartial.
Yeah.
It's in I think part of the criteria is about the time too. Are you spending an hour or 2 days?
That's the one.
Some people, it's like all day.
A constant. And you would not know you wouldn't even know they're experiencing it. Just like if I had a panic attack right now, which I'm not, you wouldn't know because it's all internal.
Well, and I think this is why maybe kind of going back to your training, and for many clinicians, they're not starting off saying, yes, I want to be an OCD specialist. But then because somebody could come in for, I'm really anxious, I have this stuff going on in life. And then turns out as we're going through a few sessions, oh, you're really, do you know that this is what's going, you have OCD, this is what's happening.
Yeah.
And we have to be trained to be able to spot it and to know how to name it. And then people might know, but they might not want to say it on their intake paperwork.
Yeah.
And because working on it is not super fun.
I was going to say, and to want to help someone clinically with OCD, it's kind of like we were talking about before with parent coaching. Like, I'm going to ask people to approach uncomfortable things and through exposure response prevention. And it is not an easy treatment. It's like, if you're afraid of heights, asking you to go all the way up there and imagine falling, like free fall, that feeling of fear. That's what it feels like for someone with OCD at times, homework. But what we do, we obviously do a fear hierarchy and we don't start all the way up there. But it's very scary for people. And I get that.
Yeah.
So it's not a fun for a therapist unless you're trained and I always had to remember when I was doing it in the beginning, I think because I treated eating disorders, I already have this background. My job isn't to make someone happy. It's to help them live the lives they want to live. And that's overcoming fear because fear pushes us around and makes our world smaller. And same thing with OCD.
Same about that.
So I think you probably know if you saw my website, I not only do CBT, but I also very well versed in ACT. I don't know very well versed, but I'm an ACT specialist. And that's...
What's that stand for?
Yeah. Give us the whole...
Acceptance and Commitment Therapy, but we don't call it ACT. We call it SC.
Yeah.
It's an acronym.
Yeah. But ERP, we don't call ERP.
No, you're right. That's a good point. Maybe we should start calling it. Maybe more people will come for treatment. But ACT is like a fourth generation cognitive behavioral. I'm going to emphasize it behavioral in that therapy. And basically, I think you asked me to say more about approaching fear.
Yeah.
So I'm sure you guys have heard this, but if I say to you, don't think of a pink elephant, what did you just picture?
Pink elephant.
Right. So if you have someone who's anxious and they say, I don't want to feel anxious, just by saying that, what are they going to know is there? Anxiety. I don't want to think about this intrusive worry. Well, just by saying it, you have the thought. So when that happens, we try to avoid the fear.
Mm-hmm.
There's no way around it, right? So when we're avoiding fear in life, it's making our world smaller. We're not doing the things that are really not, this isn't for everyone, I'm generalizing, but fear can get in the way of living the life that we want to live. If someone has a worry, I have a client who is so afraid of starting his own business and very successful, was just afraid for years. If we worked on approaching fear, I think of like, here's the person, here's the train, and where's the train driving you? Are you going where you want to go? So we want to make people's worlds bigger, depending on whatever their values are. I don't want to tell someone what to do. It's do you want to do and what's getting in the way? And it's often fear. Yeah. So if we can learn that fear and anxiety is a feeling, it's an experience, and it's quite frightening. And we don't have to get into what happens with fight or flight or blah, 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 but it feels bad and it's scary, very frightening. So then we avoid that feeling. So if I can help people approach it and be with it and still live the life they want to live, paradoxically, often that power of fear will be taken away over time. So I mentioned I had panic disorder growing up. I'm not afraid of having a panic attack at all whatsoever. So it took the power out of it, but I had to have panic attacks for that to happen. If that
it makes so much sense. And it's so, I love how simple it's so true for all of us, I think, at some point in our lives that we're going to have avoidance with something.
Yeah.
And how that can create this inward experience. And when something, and anxiety just lives in silence, like it just breeds itself and doubles and doubles and doubles in on itself when it's not allowed to come out.
It's pervasive.
Oh, totally. And yeah, like how you say it makes our world smaller, it makes us smaller.
Yeah.
And on the other side of the coin, I think is what we hear in the therapy room all the time is I regret not doing it earlier, taking the leap, trusting myself. And
you're speaking ACT language, values, right? Yeah.
And so, being able to take the leap and talk about it and process it. And anxiety often makes us go against our value system.
No doubt. I can give you guys an anecdotal, and I also want to consider it's like more of the medical, like once a conceptualization. So, and for anyone listening who has anxiety, I'll share a personal experience of how to overcome it. When my daughter is older now, but she went to college during the pandemic. Not a good time. No. She went across the country. She herself had some anxiety, understandably, but I got into the worry spiral and I would get sick to my stomach with worry. And my consultant, who's an ACT consultant, we worked on it together. And literally, you learn how to get curious about what's going on in your body, because an emotion, including anxiety, there's an anatomy, right? It's a thought. That's what it is. It's a cluster of thoughts. It's a cluster of internal sensations and urges to get rid of it or to get more of it if it's a pleasurable emotion. That's the anatomy of an emotion. And we try not to have those physical sensations. That's just like a normal thing if it's uncomfortable. And for whatever reason, my anxiety shows up in my stomach. So my ACT consultant I hate roller coasters, like the log flume, that dropping feeling is like the
I
most.
have just discovered roller coasters.
Don't you love it? You like it?
Yeah. Looking upset.
Okay, I'm not sure what's going on in your childhood. We need to talk about that.
Yes, that we can do the childhood. That'll be a second.
Do you like that feeling?
Yeah.
Do you, Kaila?
Well, because I think I like it because it's terrifying and it's so uncomfortable. And then but there's nothing to do but move through it. And then I realize I'm not dead. Yeah. It's almost like it's
an exposure.
An inner experience.
It is. Yeah. So what we worked on when I was processing my fear of my daughter, and it was totally irrational, whatever I was thinking and feeling, literally in my mind, I would put my hands up like I was going down a roller coaster to allow the physical sensations run through my body, like you were saying, to learn not to be afraid. And it's petrifying. Those feelings you think you could kind of pass out or black out or whatever it is, it's very visceral and uncomfortable for a lot of people, not for everyone. So that's the epitome of exposure, letting yourself invite it in, bring it on is what we say.
Accept it. Bring it on. It's the like, this is happening. And there is, to go with that analogy, it's like, it's on the track. You got to ride through it. You're not getting off once you're on.
No, you're not. It's too late unless you were like me as a child who screamed bloody murder. And they stopped the roller coaster to let me off.
You're like,
it was the Buccaneer, not the roller coaster.
Okay.
But I reinforced my fear by not letting myself experience
There's a saying, I grew up riding horses, and there's a saying, you always have to get back on the horse.
It's the same thing.
After something happens, and and not buying into the, like, if you don't get back on, there's a chance that in that moment, there's a chance you might not ever get back on.
Exactly. And that doesn't mean we're ever going to like the feeling, right? So that's the other thing. Like, I don't want to go on a roller coaster. I don't want to get sick if I'm nauseous. I'll use that as an example, or have a migraine or whatever it is. But I can have it. And that's how we treat OCD now.
You don't have to change your whole life to avoid discomfort. Yeah.
And you can actually experience it over and over, and it's not going to hurt you. And that doesn't mean if you go through exposure therapy, whether it's for anxiety or OCD, that you're not going to feel scared again. This is the inhibitory learning. What the learning is, I can be okay even with this anxiety. Like, this is an experience I'm having.
Yes. And it really can break the narrative if you get through it and just stay on the ride and get back on the horse, that I can do this.
Yeah.
And our brains are just so powerful. They're so powerful. They tell us these messages that, like, we believe this is threatening. This is dangerous. Get out. Like, abort mission. We don't want to do this.
It's a false sense of danger. Yeah.
False sense. Yes. And also a false sense of security in quitting.
For sure.
And safety, that it's not actually, leaving your house to get in a car, going on an airplane, things that are really crippling for some people.
Yes.
That struggle with OCD and anxiety. It can be extremely overwhelming. And then when you do it, it's like, okay.
Even with illness, you mentioned illness, anxiety with the pandemic, that didn't help, right?
Yeah.
Well, and what's OCD and what's the pandemic,
Yeah,
it was
what's real and what's not.
Assessment was really hard when something is legitimately terrifying and risky, and then also somebody has OCD presentation.
Yeah, it can be really, And one way that we also, as incorporating ACT, is, well, why would we do something difficult if it's that difficult? And basically, it's what you mentioned earlier. When I look back, let's say I'm like 95 years old and I'm like lying in my bed and I'm still alive, but I can't do as much as I used to. Am I going to look back and feel like I lived the life I want to live? I did the things I want to do? Or am I going to have regrets, which you mentioned earlier? And I try to use that in my mind. We talk about sprinkling values when we wake up in the morning. I love sprinkles, so I like colored ones. But if you're going to sprinkle a value or two, like, what am I going to do that's hard today, but I'm still going to do it because I want to, because it's important for the way I show up in this world. And if you have that framework, it makes it easier to treat or to engage in exposure response prevention or exposure therapy in general.
Yeah, like why do it? It's really hard to see the long game when you're in it, and people do get through it. Yeah.
And go ahead.
I was just going to say, I remember some of the most challenging cases with doing exposure work have to do with people who, to their credit, over years of suffering have built up entire systems around. And so doing the exposure work is like not only targeting the intrusive thoughts and some of the behaviors, but it's like breaking down their entire system of well-being, the type of place they've chosen to live in, which floor it's on, their wardrobe, the kind of car they drive, or they don't drive at all. Like it's so it's interesting also like at what stage in the intervention happens in their own process and how they've managed it on their own.
That's huge for any provider of OCD to do a deep assessment and understand the safety behaviors, right? And you're right. It's like someone who's had OCD for years, they're doing things that they don't even know are avoidance behaviors. And you're right, they create systems. And that takes time to understand and to continue to reassess. And I'm a firm believer that the most important thing in treating OCD is response prevention, not engaging in compulsions. Exposure is important, but response prevention, taking away the compulsions, is you'll have a natural exposure no matter what if you can't compulse.
Can you give an example?
Ooh, yeah. If I'm treating someone who has harm OCD and they're afraid they're going to hurt themselves, I have several teens who have this. Like they have a fear of killing themselves. And clearly, if it's a fear, they really don't want to do that, obviously, but it's such a frightening thought to have. We're not going to do exposures with imagining killing themselves because that would be highly distressing for anybody. But we are going to find out all of the compulsions they're doing, whether it's mental or like if they're kind of reassuring themselves over and over, or they're staying away from dangerous.
Like they don't go in the kitchen because there's knives in the kitchen.
Or scissors, or they don't use razors or whatever it is. So we're going to have to really take time to figure out what are they doing mentally to prevent or to reduce their intrusive worry. And then we're going to slowly help them no longer have those mental compulsions, which is tricky. Because it's not like you can say, oh, don't wash your hands. So often with mental compulsions, if we weren't going to do exposure, we might do something called a NER. I just like saying that. My teens love it. It's called a non-engagement response, where we just agree with the thought. That shuts it up. You can't argue. If you say, yeah, I'm going to kill myself. They're not going to kill themselves, and I'm going to try it. But agreeing with the thought is frightening, and at the same time, you can't argue with the thought.
I'm going to drag my car into oncoming traffic.
Oh, that's such a common one.
That's a common one.
I have the, I mean, we all
What if
have
that
these.
happens?
Yeah.
What if I drive my car off the cliff? Like, and there is data that really backs up that like harm OCD is the like least likely population to
hurt themselves.
Hurt others.
Yeah.
Yeah. So
Yeah.
As long as that's the only thing going on.
yes.
Yeah. Yes. If
Caveat
there's comorbidity, I like that you're being conservative here, sir. I mean, believe me, I am very conservative in my assessment. Like if there isn't obviously, some type of suicidality thoughts or intention or even passive suicidality, we want to assess for that. But even like, I'll say a taboo thing, like pedophile OCD, people have it. Like they have it. But that doesn't mean they want to do something horrific. It means they're afraid that they're having this thought. But just that they're afraid and they don't want it brings back the thought. So learning, that's called thought fusion. Just because you're having a thought doesn't mean you're going to do it. Right? But then they're like, no, I'm having this thought that things I want to do. This must mean I want to do it. But usually whatever worry there is, there's usually a core theme or a feared possible self that I'm going to be this person. And what I have found over and over, because you do want to find out what their core fear is and address that, it's always, I'm going to be anxious forever or doomed forever or, alone forever. I'm not going to be able to tolerate this feeling of anxiety or depression. So we often have to do exposures with that later. And I really find that to be incredibly powerful, uncomfortable, but powerful.
I think there's, it's the learning to like yourself and to accept yourself and this work of finding who you are and the burden, the worthlessness, these things come from
stuff,
our own learned experiences and traumas and
our own learned history somewhere along the line. You can't unlearn what you've learned. You can't unlearn 2 + 2, right? But you can add to that learning by learning how to see it for what it is. It's just a feared thought.
Yeah.
And feeling.
Yeah.
I feel like that's why that ends up being important in part of the educational process to separate the thoughts that are happening away from who they are as a person.
It's 5,000%. Yeah. And they don't believe you. But OCD, it's called the doubting disease.
Yeah.
So they don't believe it.
Yeah.
And Robin Walzer, my consultant, taught me this one: belief not required. When she first said that to me, I was like, wait, what? Because you have to think about what that means. But you don't have to believe it.
I say that about medication sometimes too. Oh, that is somewhat, there's a mixture where they're not that totally true, but sometimes it's useful.
Well, speaking of medicine, we started to talk about this earlier. I think for OCD, it's tricky because people do need to be typically on higher doses for it to be therapeutic, but they hear that and think that there's something really wrong with them, which makes me so sad because that has nothing to do with it. I wish people could think about mental health illness, like if there's something wrong with their heart, another organ, they would treat it in 2 seconds. But for some reason, taking medicine to help with something they're struggling with or suffering with, it still has a stigma, or they're afraid it's going to they're not educated, or there's not enough education. They think it's going to change their personality, yada, yada, yada. So I imagine part of your work is tons of psychoeducation.
Yeah, it's interesting. I don't know that I've heard the doubting disease.
Oh, that's what it's called.
Like so on brand. But I would say even now, recently, I found some success in setting the frame in the beginning. Once I've either they come to me saying, my therapist, my psychologist has said I have OCD and need some assistance, medication support. Or if I find it on my own, it's kind of like this hidden thing. I set it up differently. So I'm like, you're going to look this up. Of course, you're going to look it up. He's going to use medication.
They're going to chat GPT it.
200 milligrams of Zoloft. You're going to see that's the max.
Yeah.
That's not for you.
That's great.
The 400 milligram max, that's for you.
Yeah,
and so if we get to 200, we're only at 50%.
That is so
and so
good
then
to
they're
say.
Oh, I'm not maxing out the dose. I'm not the sickest person on the planet. It's easier.
Yeah.
So even setting it up in the beginning to say the treatment range that we're using is totally unrelated to the FDA stuff you're going to find online.
I love
So you're
that.
only at 5% of the dose right now. So you're doing great.
That's amazing to frame it that way. And it's the truth, and it's so helpful. I mean, that is the first line. Treatment for OCD is ERP and medication, but a lot of people want to start without medication, which is fine.
Yeah. And in therapy, by and large, to my knowledge, is more effective than medication alone.
Yes, for sure. Yeah. You need something, or, it might help quell the thoughts a little bit or slow them down. But if you don't understand what's going on, you're going to keep avoiding the discomfort.
Mm-hmm. I was wondering on the illness anxiety side, such illness OCD, and somatic stuff, sensations. And I'm definitely not as skilled on the therapy side, so I'm also calling a little consultation right
Go
now.
for it. Yeah. I'll be right back at you.
But for my illness anxiety folks, it commonly starts with a sensation.
Yes.
So it's not a thought, it's a feeling experience. Yeah. So it's I feel something in my leg, or I have a cough, whatever. And so then part of it is going to the internet to see what that could be. But even once we've kind of stopped that, they've already learned so much. Like they're telling me diseases I've never heard about.
Yes. They're
But
compulsing
then-
by researching, by the way. That's
Yeah.
all compulsing. But
Yeah.
in the beginning,
Yeah.
they wouldn't know that because they generally think something's wrong with me.
But I wonder how the intrusive experience being a sensation, how you work with creating exposures, or how do you that?
I'm smiling because I had a difficult the person wasn't difficult, but he had somatic OCD.
Like bodily sensations that then are like, I'm going to die.
Bodily sensations, my muscles aren't going to work. I'm not going to be able to play piano anymore, or my eyes aren't working, so I'm not going to be able to see anymore. Things like this that are really frightening. And sometimes
blurry vision, or like a weird tingling sensation,
and so you're more, anxiety sensitivity. Some people are more aware of their internal physical sensations, and that can be like, oh, I thought I had a twitch, and then so maybe now I have ALS, for example, and then they look it up and they're going to see stuff. So part of it is psychoeducation, right? That this sounds like OCD. And if of course you want someone to go to a doctor at least once to get assessed, because I don't know, I'm not a medical provider, but when we realize that there's nothing wrong with the person, we do a lot of exposures where we focus on those sensations, it's like panic disorder, interoceptive stuff. So we sit there and we really, really focus on the fact that I'm not going to be able to blink, or that my eyes are burning me, or I'm going to have a twitch. And I'll say, let's really bring it on and see what happens in session. Will never ask someone to do something I won't do with them. That's not fair.
Isn't that an OCD therapist?
Yeah. We don't do that anymore, by the way. If anyone wants treatment, I'm not going to make you look a toilet, because I'm not going to look a toilet.
Yeah. I always thought that was bizarre.
Like
when I was
OCD therapists are like, I've done this. I've had to lick the bottom of my shoe, and I've had,
So I know I'm not gonna die, but like that's nasty. Like I'm not gonna tell you to do something you shouldn't do. Like,
we don't do that anymore. That's silly. But we do things that maybe like that we should be doing that other people with OCD are afraid to do. But we could talk about the toilet later, because with OCD there's a lot of that we talk about. But with bodily sensations, we bring them on, and then we're like, did anything happen? We magnify it almost. The somatic OCD is tricky because it turns into like illness anxiety often. So the other thing we do is no more looking things up on the internet. I often tell people, get a notebook. We get the answer once. You could ask me anything, and I'll give you reassurance once. Write it down. Yeah. If you want to look it up on the internet, write it down. If you want to talk to your doctor, of course. Most of my patients with health anxiety don't listen to me and do not go back to the doctor. But that's just a compulsion, safety behavior. It's not going to help them get over it, because OCD is never satisfied. That's when you know you're in OCD land. What if? Oh, I feel better because Dr. Lorraine said that I didn't do the wrong thing in the car the other day. I didn't kill someone or whatever, because people have this worry. And then like an hour later, but what if I didn't hear it? Or what if I really did and she doesn't know?
What if my music's too loud and I don't hear it
has tentacles. It's just and as soon as we start noticing the what ifs and that uncomfortable feeling of uncertainty, we're in OCD world. Try to teach people we identify what they feel like when they're in OCD world versus when they're not. And usually it's like something they really care about.
Yeah. That's what I was actually going to say earlier. So I'm glad we got here, because it's I'm hoping you can speak to a little bit of what it does for interpersonal relationships, and this assurance thing.
Yeah,
it's a really big deal.
It is. It's a part of the family system or partner system or whatever. I love that you asked that, because if you do some trainings in OCD, but you don't learn about assessing for family accommodations and how it shows up in the family, like any other mental health illness, like depression or general anxiety or addiction, the family needs to be taught what it is. And it can be, especially relationship OCD, that can be debilitating to the relationship. It can ruin relationships. So it has to be talked about. I often invite family members in, as long as I have release, obviously, and permission from the client, but to explain. There's a great book that I recommend to family members or loved ones about OCD. And I do an assessment on what are they doing to accommodate their reassurance seeking and how to handle it. The CBT, the space treatment. Yes. Yeah, right? So how to handle the reassurance seeking, if you keep reassuring, then we're going to
It's enabling, but then on the other hand, you feel really like you're mean.
Yes.
You don't say, of course you're not going to drive into oncoming traffic, or of course you're going to make it to school. It's going to be fine, or it's just a cold. Get over it.
Yes.
Yeah. You're not dying. What these assurances can be really damaging on one hand, and then really hard not to buy into.
It's so hard for the loved one,
especially for parents.
I know. And and I'm sure that they talk about this in the space training. I know when I did family therapy for eating disorders, you're doing it out of love and to help someone, not to hurt them. And it's not always our job to make the anxiety or OCD feel better. Is to help your loved one get through it and over it. Yeah. And a better response would be, well, what do you think your Lorraine might say to do? What skill can we do? Or I know this is really scary and uncomfortable, but I know that you can be okay with it. I'm not going to answer the question because this is OCD, even though I love you.
Mm-hmm. You're externalizing the OCD.
Oh, yeah. Big time.
Yeah.
Sometimes I feel like I remember we would tell people to kind of maybe just like demonstrate if, just give a hug or they're like, I love you so much, or not address that concern. Sometimes it would get tricky if someone was very sophisticated and would say, okay, every time you hug me, that means that you agree with what I'm saying. So it like that.
That it had turned into a compulsion, and it often does.
Yes.
Yeah. I love you. Before a teen or a kid goes to sleep saying I love you to their parents, it actually can be a compulsion. And I've had to help clients not say that or tell the parents don't say it back, which sounds horrible, but it's really not going to help that. Of course she loves your child.
Mm-hmm, mm-hmm.
And that it's for parents, I think often it's also their own self-preservation, because I don't have time for a meltdown right now. We can't have, if I say no to this thing, or if I don't give in, then what is this going to do to the day and the schedule and the timing? And
it's hard.
And so in public. And so I have so much compassion for families.
I do too.
Go through this. And I think a lot of work I work with a lot of parents. It sounds like you do too, that how are you regulating through, and partners? Yeah. How are you regulating in these moments when this person you love is struggling? Yeah. And that's so hard once you've been their person, their safe space, to kind of pull the rug out from this dynamic. Yeah. Is so tricky, and you're going to make it worse. Yeah. It's not going to be fun for really anybody. Yeah. Especially for little kids that can tantrum and get angry and big. And and so really developing the resourcing for parents is just
huge. Yeah. Or a loved one, a partner.
And it's not going to last forever.
Right. Yeah.
We're going to get through this hard stuff. But being in that place to not, I think on one hand, not sugarcoat it and say this is all going to be easy. And then on the other hand, not over catastrophizing it. And buying into how bad it's going to be. Because ultimately, we're all doing this out of a good place.
And it's normal for a parent to feel anxious when they see their child or their teen anxious. It's very scary. So like you're saying, like, what are they doing to help themselves and to regulate their emotions? It's tricky. Yeah. And as a parent, I know that.
And it starts from a loving place. Typically, it doesn't start out as extreme as where by the time they find a therapist or a psychiatrist and are getting treatment. Yeah. It starts out with these little micro things that turn into bigger anxieties and fears. And then, and then you're a couple of years in and it's like, oh, we gotta get help. And then, it's not uncommon that we hear, we saw a therapist and then we saw another therapist and then we blew out of that therapy. And then, and so I think also, and you can speak to this a little bit, like what does your informed consent look like, and what does the process look like of kind of, I say it's almost like a pitch, like it's almost like setting the expectation for what it's going to look like is a huge it's really important.
Shoot, I'm so glad you brought that up, because I feel like nowadays with electronic health records, by the way, I love the talk on AI that you guys did, because we'll talk about that offline. That's been an interesting thing. But informed consent is huge. And I think a lot of times therapists just like send the forms out and people sign them, but they don't know really what they're signing up for. And for any type of exposure therapy, it's important for clients to agree and understand what they're going to be doing, and that they're going to feel uncomfortable. It's going to be scary. I'm probably going to prod them along with their permission, because I don't want to accommodate the anxiety. Also incorporating how important it is to do family work if they're willing, because in a way, if they do live with someone else or they're close to someone else, we're not fully treating the problem. So all those things need to be discussed up front. And informed consent is dynamic. It's not static. Once they say yes, it can change at any time. I always want to, sounded Southern there. I always want to empower my patients to know that if this is too much, let me know. We'll take a pause. We can hit a pause button and talk about it. I think that's really important. Otherwise, we're going to lose people. Attrition. Yes. The other thing I just thought of as we're talking about health anxiety and OCD and anxiety, perfectionism, indecisiveness, I would add those into kind of like, obviously like trichotillomania and skin picking are kind of BFRBs, are forms, derivatives of the OCD spectrum, but so is perfectionism. And indecisiveness can fall into that bucket as well.
Feel like I'm the same.
I find they show up together a lot.
Yeah. In the realm of, and also disordered eating. Yeah. It's the control and the, it's so hard when our ego just wants absolutes. We want control.
We do.
It's so tantalizing.
Yeah. It gives us a sense of efficacy or fault. Think about it. We want control, but do we really have control over anything? Do we really? And certainty. We want certainty.
And some people are just more comfortable. Some temperaments are just more comfortable with that than others. And I always think it's funny when people find each other, just as an anecdote. I do think it's funny when one person, like partnerships, and what people find each other that are on opposite ends of these spectrums.
Yes.
And it comes up in parenting and couples work all the time. And so it's interesting.
It's fascinating. Yeah. It is. We're drawn to our opposites, maybe. I don't know.
Yeah. Or the need.
That's interesting. Yeah. Because like in a relationship, maybe a different temperament or opposing temperament like is a good balance, but then when you're parenting, you're like, wait, what would?
Yes.
Reminding each other, and it comes out in the therapy space all the time, and especially for kids that have anxiety, how to talk about anxiety, like just full circle to your childhood and probably so many people's childhoods. How to talk about fears. It's like so easy to minimize kids.
It is.
And that like whatever kids are going through is very real for them. And we minimize them all the time.
All the time. And that can have profound effects.
I agree.
Because you think what you're feeling or what you're thinking, whatever your internal experience is, that it doesn't matter. You're not attuning. As I know you're probably way more into attachment than I am, but I know a little bit about attachment. And when you're not attuning to someone's experience, then you're kind of minimizing them and telling them what they're experiencing doesn't matter. And that can create a lifetime of self-doubt, which it's mind-boggling, right? Remember, you can't unlearn what you've learned.
It's the template for our jumping off point for our lives.
I know. Childhood.
Yes. And how that inner voice, there's that saying that our own inner critic is the voice of our most critical parent.
It's so true.
It's like, who's talking right now?
Oh, yeah.
You, or is that your...
Whose voice you hear? Yeah. And just in general, like, I think anxiety in general, like, we are taught growing up, and even nowadays, especially where we live and, live in the Silicon Valley, that anxiety is bad. But you know what? Anxiety is real and is natural and is not always bad. It's a form of protection. And so helping people understand that it can't hurt you, it's just uncomfortable, and to kind of destigmatize it, that it's just part of some people's experience, which is not a bad thing, I think can be very freeing. There is one more thing I just realized I want to cover about anxiety and OCD and therapy and life. I think like a sense of humor is just so important. We, remember that old, you may not remember the Don't Sweat the Small Stuff. It's a book from the past, but we can be very serious, and that's important. I don't want to minimize that at all, but I think humor helps us remember things that we may not remember. And I would say that's an asset I can say I'm proud of that I have. And it just helps life in general. So I just really like to invite my clients or my colleagues or anyone in my sphere, like, it's okay to be silly sometimes. Bring that into the world. It's okay. And it's good. It's healthy. I don't know the research.
It's like a PSA.
Yeah.
To have fun and to laugh and to giggle and
and it's relationship building.
It's connection. Yes. Yeah. Totally.
Yeah. Thanks for I definitely will drop some inappropriate language here and there. To some degree of efficacy and humor, sometimes not so much, but I will do that.
You swear? My word.
Let's do an exposure right now.
I don't see children, so
I'm getting you. My teens love when I swear.
Oh, teens love it.
Oh, they're like, she's cool.
Oh, yeah. My dad was a high school teacher, and he swore all the time. His favorite word was the F word.
Oh, yeah. So the kids must have loved that.
They thought he was so cool.
Yeah.
Oh, yeah. Lots of F-bombs going off all the time.
Yeah.
Let him rip.
Yeah.
Oh, yeah. I was having a session with a client recently, and somebody came out. We were all in the office, and another therapist came out, and they were like, "You were having so much fun in that session. I don't know what was going on. Couldn't hear anything, but I just heard laughter as I walked past the door."
That's great. So
that's therapy. You can have therapy can look like all different things.
It can.
Yeah.
Well, tell us about your practice and what it looks like.
Yeah. So I have a practice called Choice Point Counseling in Menlo Park. I have an office that people can come into. I also do work virtually, and I don't only see people in California. I'm licensed in several other states.
You're an overachiever.
I'm an overachiever. No, I actually do that for the clients that I've been seeing in high school.
That's really sweet.
It's such a hard time for them to go to college and not know their therapist. That's just...
Especially depending on where they go to school. A lot of schools don't offer mental health services.
Or they have 4 sessions, 30.
Start over with somebody that you've been working with long term. And it's really an issue.
It is.
In our field that there isn't portability.
Yes. And unfortunately, I don't know if we're ever going to have site pack here in California.
I don't know.
So my private practice, I specialize in the things that you heard about before. I like to be very informal. I know I'm a doctor and there's a patient-doctor relationship, but the way I work is more collaboratively. This is an stance that we're both human beings. We both have had struggles in life. We both experienced things, and I happen to have a set of skills that I can help you with. And that's how I approach treatments. I never want clients to feel intimidated in any way. I understand in the beginning it might be that way because you have the power differential deciding about their mental health. But I ask for a lot of feedback. So I tell my clients, I'm not psychoanalyzing you. I can't read your mind. I wasn't trained in how to do that. But I do have skills that I can help you with and build a relationship and hopefully mirror things about yourself that you've never known before, But the good thing about the website, it does have some good resources of books or workshops that I would highly recommend for clients that are struggling in different areas. I put my faves.
Great.
Sure.
Awesome.
Yeah.
So we usually start with this question, but we're going to end.
You weren't going to ask me, and I've been thinking about
where we ask everybody, and I actually like ending on this. This is fun. We ask everybody, like, what's on your mind? Not related to the subject necessarily that you came in to talk about today, but just what's on your mind in general.
Yeah.
And we love knowing.
Yeah. Well, I have 3. One of them I already talked about, which is how, like, the anxiety train, like, just how prevalent anxiety is and in a kind of thinking about what's important in your life and how can you make your life bigger and not smaller. So we already covered that one. The other one I think is really important is that mental health doesn't discriminate. And I think I mentioned this earlier. And that's a humbling thing to think about. We all have implicit bias. Like, we can't even help it, right? That you can't unlearn what you've learned. And so, you know, I've worked with so many different populations, and I think you have too. Like, you try working in locked units and, you know, and you probably too working with families, you see so many different
downtown San Francisco too.
To work in the Tenderloin.
Oh, you worked in the Tenderloin. Yeah, so you know what I'm talking about. So we sometimes make assumptions that maybe like addiction only lives in like lower socioeconomic places, or, you know, we just make assumptions. And I think it's really important for people to understand that schizophrenia can hit anyone. Right? Addiction can hit anyone. OCD can hit anyone, not to scare anyone, but I think it's important for us to remember that to help destigmatize things. And the third has nothing to do with that. I'm just going to give a plug that I'm really into music and Kendrick Lamar. I was in love with him before he was ever famous. I hope he hears this one day. When he was like mixtape Section 80. And the reason why is because he is very raw and real with really important topics that never would have reached the amount of people that it has because of his talent. And I just have the utmost respect for him. You know, he talks about identity. Yes, he talks about oppression and culture, but he also talks about mental illness and really uncomfortable topics. You may not know this, but on Mr. Morales and the Big Steppers, Eckhart Tolle is on his album throughout.
Oh.
And he talks about his journey, not Eckhart Tolle, but Kendrick Lamar talks about his struggles with mental health. And I'm just have always been very moved by him. And so I wanted to say that because I wanted somehow him to know this. So when I started a podcast.
We definitely have made it if Kendrick.
Oh my God. And when I start a podcast one day, maybe he'll be a guest. But more important.
We're going to give you this social clip and you're going to blast it to find.
Just DM.
Yeah.
But more importantly, like his way of learning before he went to therapy was music, his outlet. So finding what your passion is and not letting that stop you from doing, like, he made his world bigger because he approached what was important to him. I didn't know I was going to say that.
Yeah.
That's beautiful.
Thank you.
Thank you.
Yeah. Well, that's a perfect place to end. You know, Kendrick, please like, subscribe.
Yeah.
So you send Eric right now.
Here. Oh, thank you so much for being on here today. We will link your website and your LinkedIn, and people can find you. Okay. And yeah, don't forget to like, subscribe if you made it this far into the episode. Leave us a review, and we will catch you next time. I'm Kaila.
I'm Dr. Sir.
Thanks for listening. Thank you. Bye.